Welcome back to Roadmap to Residency. In this video, we are going to work through high-yield test-taking strategies for pneumonia and respiratory failure on the Step 3 examination. We will cover antibiotic selection and de-escalation, supplemental oxygen strategies, ventilator management basics, and the criteria for removing the breathing tube. But here is the important part. Our goal today is not to teach you all of pulmonary medicine. Our goal is to show you how these questions are written, how to read the clinical stem quickly, and how to choose the best answer under time pressure. Lean on your trusted board review book, your question bank, and a reliable management reference for the underlying content. Here we focus on strategy. If this is helpful, please like and subscribe, and stay with me to the end. Here is what we will cover. First, we will learn to read the stem signals. Pneumonia and respiratory failure questions are loaded with buzzwords that quietly point you toward the right antibiotic, the right oxygen device, and the right ventilator move. Second, we will master the management ladder. The exam loves to ask for the next best step, when to escalate breathing support, and just as often, when to pull back and de-escalate. Third, we will walk through 4 board-style questions together, and I will give you a reason for every right answer and every wrong answer. For the underlying facts, keep using your favorite board review book, your question bank, and a reliable critical care reference. This video is about applying that knowledge on exam day. Before we touch a single question, understand how these topics are actually tested. On the left, pneumonia. These questions rarely ask you to name the organism. Instead, they ask you to choose the right starting antibiotic based on where the patient got sick and how sick they are. Then, a few days later, they ask you to narrow that antibiotic once cultures return and the patient is improving. The examination rewards the resident who treats broadly at first and then de-escalates. Watch 3 things: the setting, the severity, and the culture result. Those decide the answer far more often than the chest film. On the right, respiratory failure. This is a ladder. You start with simple supplemental oxygen, you climb to high-flow or non-invasive support, and you place a breathing tube only when those fail or the airway is unsafe. Once the patient is on the ventilator, the questions move to safe settings and then to weaning. Escalate when the patient is failing, and pull support the moment the patient is ready. Match your action to where the patient sits on that ladder. Almost every pneumonia and respiratory failure question on this exam falls into one of 4 buckets. Bucket 1, antibiotics. You pick the starting regimen by the setting and the severity. Then you de-escalate when both the cultures and the patient improve. Community pneumonia, hospital pneumonia, and ventilator-associated pneumonia each have a different starting answer, and the exam expects you to know which is which. Bucket 2, oxygen and support. You climb the ladder in order: simple oxygen first, then high-flow or non-invasive support, then a breathing tube. The stem tells you which rung the patient needs through the oxygen saturation and the work of breathing. Bucket 3, ventilator and weaning. Use lung protective settings, fix low oxygen with the agreed knobs, and run a daily breathing trial. You remove the tube when the patient passes that trial, is awake, and can protect the airway. The bottom line: most questions here are really asking where the patient sits on the ladder and whether it is time to climb or time to step down. Here is a comparison the exam tests constantly. Does this patient look like an outpatient, or does this patient look severe? On the left, the outpatient picture. A younger patient with a cough, a fever, and a focal area on the chest film, but with normal vital signs, a clear mind, and a normal oxygen level. The stem is steering you toward a simple oral regimen and treatment at home. Notice what is absent. No confusion, no very low blood pressure, no fast breathing rate, no low oxygen level. When those reassuring features line up, the exam wants the least aggressive correct choice, not a hospital admission. On the right, the severe picture. Now the stem layers in danger signs: new confusion, a rising breathing rate, blood pressure that does not respond to fluids, or an oxygen level that keeps falling. Each of these pushes the patient toward the hospital, and several together push toward the intensive care unit and broader antibiotics. The examination plants these words on purpose. Train yourself to spot 4 things: confusion, breathing rate, blood pressure, and oxygen. That cluster decides the setting, and the setting decides the antibiotic. Every question we walk through today uses the same 4-step rhythm, so let us lock it in now. First, read the last line first. The final sentence tells you whether the question wants a starting antibiotic, a de-escalation, an oxygen device, or a ventilator change? Those are four completely different answers, so know which one is being asked before you read the story. Second, find the setting and the severity. Where did the patient get sick, and how sick are they right now? Setting and severity choose the antibiotic, and they choose the rung on the support ladder. Third, predict before you peak. Form your management answer before you read the choices, so that attempting broad antibiotic or an early breathing tube cannot pull you off course when a narrower step is actually correct. Fourth, eliminate by escalation level. Cross out the choices that escalate too far or pull back too soon. The right answer matches the exact rung the patient needs at this moment. Read the last line, find setting and severity, predict, and eliminate by escalation level. Let us use it. Let us put the strategy to work with our first question, which tests antibiotic selection. A previously healthy 30-year-old woman comes to the clinic with 3 days of fever, a productive cough, and a single focal area of consolidation on her chest film. She is alert and comfortable. Her breathing rate, her blood pressure, and her oxygen level are all normal. She has no other medical problems and no recent hospital stay or antibiotics. The question asks for the most appropriate management. Your choices are: treat as an outpatient with a recommended oral antibiotic regimen, admit to the hospital for broad intravenous antibiotics covering resistant organisms, admit to the intensive care unit and start antibiotics for ventilator pneumonia, or withhold antibiotics and repeat the chest film in 6 weeks. Pause here, read the last line, find the setting and severity, and predict your answer before we walk through it together. Here is the walkthrough. Spot the setting first. This patient got sick out in the community, not inside a hospital. She is young, she is healthy, she is fully alert, and every vital sign is normal. There is not a single danger sign anywhere in the stem. This is straightforward community-acquired pneumonia in a low-risk patient. Now apply the rule. A healthy outpatient with community pneumonia and no danger signs is treated at home with a recommended oral antibiotic regimen. You match the least aggressive correct treatment to a low-severity setting. That makes the answer A. Now eliminate the wrong choices. Broad intravenous antibiotics for resistant organisms, choice B, and ventilator pneumonia coverage in the intensive care unit, choice C, both massively overtreat a well patient. These are the classic too much traps the exam plants to punish panic. Withholding antibiotics and repeating the film, choice D, ignores a real pneumonia that needs treatment now. The correct answer is A. The lesson: when the vital signs are calm and the patient is low risk, resist the urge to escalate. The exam rewards the resident who treats appropriately, not aggressively. Question 2 tests de-escalation, which is one of the most reliably tested ideas in this whole topic. A patient admitted with severe pneumonia was started on broad antibiotics that cover resistant organisms. After 3 days, the blood and respiratory cultures grow a single common bacterium that is sensitive to a narrow antibiotic. The patient is now afebrile, is breathing comfortably, and is clearly improving. The question asks for the most appropriate next step. Your choices are: narrow the antibiotics to target the identified organism, continue the broad antibiotics unchanged for a full 2 weeks, add a second broad agent to cover possible resistant organisms, or stop all antibiotics today because the patient is improving. Predict your answer and let us walk through it. Question 3 tests supplemental oxygen strategy, which is really a question about climbing the support ladder one rung at a time. A patient with severe pneumonia is on a simple nasal oxygen device, but remains short of breath, with a rising breathing rate and an oxygen level that stays low even when you turn the flow up. Importantly, the patient is awake, following commands, and protecting the airway, and the blood is not yet dangerously acidic. The question asks for the most appropriate next step. Your choices are: escalate to high-flow nasal oxygen or non-invasive positive pressure support, immediately place a breathing tube and start the ventilator, remove the oxygen and observe off support, or make no change and recheck the oxygen level in the morning. Predict your next rung and let us walk through it. Here is the walkthrough. Match the rung to the patient. Simple oxygen is failing, so yes, this patient clearly needs more support. But look closely at the safety signals the stem gives you. The patient is awake, is following commands, is protecting the airway, and is not yet severely acidic. Because all of those are reassuring, the next correct rung is high-flow nasal oxygen, or non-invasive positive pressure support, not an immediate breathing tube. You escalate one level and then you reassess. That makes the answer A. Now the pearl and why the rest are wrong. Placing a breathing tube right away, choice B, skips a rung in a patient who is still safe enough to try non-invasive support, and the exam treats that as escalating too far, too fast. Removing the oxygen, choice C, and waiting until morning, choice D, both pull back at the exact moment the patient is failing, and both are clearly unsafe. The oxygen ladder pearl is simple, climb in order. Simple oxygen, then high flow or non-invasive support, then a breathing tube only when those fail or the airway becomes unsafe. The correct answer is A. Our final question brings together ventilator management and the criteria for removing the breathing tube. A patient on the ventilator for pneumonia has steadily improved. The underlying infection is controlled, the oxygen needs are now low on minimal settings, the patient is awake and following commands, has an active cough, and tolerates a spontaneous breathing trial comfortably for 30 minutes. The question asks which finding best indicates that the patient is ready to have the breathing tube removed. Your choices are: the patient passes a spontaneous breathing trial, is awake, and can protect the airway. A single morning oxygen level is normal while still on full ventilator support. The chest film has completely cleared of all consolidation, or the patient has been on the ventilator for at least 10 days. Predict your answer and let us finish strong. Here is the final walkthrough. Build the checklist. Readiness to remove the breathing tube is a checklist, not any single number. Run through it. The underlying cause is improving. The patient breathes well on minimal settings and tolerates a spontaneous breathing trial. The patient is awake and following commands, and the patient has a strong cough to protect the airway. Choice A names exactly that combination, so the answer is A. Now, why are the rest wrong? A normal oxygen level while still on full ventilator support, choice B, only proves the machine is doing its job. It says nothing about whether the patient can breathe on their own. A perfectly clear chest film, choice C, is not required for removing the tube, and the film often lags well behind the patient's actual recovery. A fixed number of days on the ventilator, choice D, is arbitrary. There is no magic day count that makes someone ready. Only the spontaneous breathing trial, combined with an awake, airway-protecting patient, signals true readiness, so the correct answer is A. Keep that checklist in your head. Cause improving, breathing trial passed, awake, and protecting the airway. Let us bring it home. First, study smart. Lean on your question bank, your board review book, and a trusted critical care reference for the underlying facts. Drill 4 things until they are automatic. Antibiotic selection by setting and severity. De-escalation, when cultures and the patient both improve. The oxygen ladder, and the criteria for removing the breathing tube. Second, practice the strategy we used in every question today. Read the last line first, find the setting and severity. Predict your answer, and eliminate by escalation level. Climb the ladder when the patient is failing, and step down the moment the patient is ready. That rhythm will carry you through these questions on exam day. If this video helped you, please like and subscribe so more residents can find it. And when you want personal guidance, visit roadmaptoresidency.com, where our expert tutors and residency advisors are ready to help you pass comfortably and match strong. Thank you for studying with us, and we will see you in the next video.